Uh, Good morning, everyone. Today I'm going to discuss past paper exam. It's May 2017 for third med students in National University of Ireland, Galway, and NUIG. So the first question, it is in the field of geriatric medicine, care of the elderly. Here we have an 87-year-old man attend the emergency department accompanied by his son, complaining of confusion and agitation. This is very important. He has these the chief complaint. It is confusion and agitation. His son, who lives with him but works outside the home during the day, noticed that his father was recently getting his words mixed up, was not able to maintain conversation for very long, and could not remember the day of the week. So the patient has element of loss of memory, and this memory, it is short-term memory. So far from the question, we can understand that we have old age male patient who had seems to be acute onset of confusion, agitation, and loss of short-term memory. So he also noticed that his father was up 3 to 4 times at night to use the toilet, and that he had bruising in his knees. So here we have two other complaints or other symptoms. The patient is waking up during the night 3-4 times, so and going to the bathroom. So this is this one. And the other things here, we have the son noticed that his father has bruising in his knee. So we have element of bleeding, bruising in the knee. So here we have 3 things in this question we have to think about. We have acute onset of confusion and agitation, and we have confusion and agitation, and as well loss of short-term memory. All of these, it's connected in the same group of symptoms. And other group of symptoms, the patient is recently started acute onset of nocturia or frequency during the night, nocturnal frequency. And the other things, we have acute onset of knee bruises or element of bleeding in the knees. So past medical history, here we have ischemic heart disease, hypertension, atrial fibrillation, Parkinson's disease. And this is the usual group of disease, can be seen in elderly and this kind of patients. Current medication are warfarin. This is very important. Warfarin, it is oral anticoagulant. Most likely it's used for atrial fibrillation here. Perindopril, it is ACE inhibitor. It is indirect vasodilator. Most likely it's used for ischemic heart disease and for hypertension. Cinemet, it is a combination of 2 drugs. It is carbidopa and levodopa. This is dopamine precursor. It is the first-line medical treatment for, or pharmacological treatment for, Parkinson's disease. The patient on paracetamol, this is painkiller. Zabiclone, this is sedative agent. And the patient, he's taking codeine. Codeine, this is weak type of opioid medication used for analgesia. So we have to, it's very important to know what's the pharmacological class for each medication and what's the effect of each medication, because there is a few questions related to pharmacology and related to medication. So he is compliant with his medication, and he has no known drug allergies. Finding on examination are blood pressure 110/65, which is accepted, normal. Heart rate 110, he is tachycardic. Respiratory rate 20, it's accepted, normal. Auto saturation 98 on room air, this is normal. Temperature 38.2, so he had temperature. This temperature is a low-grade temperature, but he has a low-grade temperature. Examination was otherwise normal, apart from some. So here, very important to notice that the patient is febrile and the patient is tachycardic, and this tachycardia, it can be explained by temperature. So examination otherwise normal apart from some suprapubic tenderness. This indicates, very important, because the patient has a new onset of nocturnal frequency. He's waking up too much during the night and going in, and he's going into toilet. So this is indicate that the patient the patient might have some element of lower UTI with this suprapubic tenderness. It can indicate cystitis, and given the rise of temperature and given the history of recent history of waking up 3 to 4 times at the night time. So here, let's start. He is screened positive for frailty on admission. So we have for this kind of patient, elderly patient, we have scoring system for frailty, and the patient screened positive for this. First, there is multiple questions. This is the question number 1 in this short answer question. Provide 2 likely causes for his cognitive decline and 2 for his physical decline. He is asking here about the causes or the likely causes. The cognitive decline, the patient has a new onset of confusion, agitation, and loss of memory or short-term memory. This is the cognitive decline the patient has, and he's asking what's the 2 likely causes for this. And 2 causes for his physical decline. Physical decline, we have here a new onset of nocturnal frequency, and the patient has in the examination suprapubic tenderness. This is one or first physical decline, and the other thing, the patient has bruising in his knees. So what do you think? The most likely, the 2 likely causes of his cognitive decline, it could be acute onset of delirium, and this delirium, the cause of this delirium, most likely according to the scenario, could be infection induced. To be more specific, it is lower UTI induced, and it could be this UTI causing sepsis and the sepsis causing this acute delirium. This is one of the important cause. The other cause is dementia. The patient might have dementia. So if we are talking about delirium, acute delirium, could be the underlying cause or contributing factor for delirium is the infection, which is UTI, that might cause sepsis, and this sepsis can contribute to acute onset of delirium. Dementia, it could be one of the differential. And if we are talking about dementia, we have dementia, it's the old terminology. Now the new terminology, it's called neurocognitive disorder, NCD. The NCD, could be mild neurocognitive disorder, or the previous terminology for mild neurocognitive disorder, it is mild cognitive impairment, or it could be major cognitive impairment or major neurocognitive disorder. So the 2 groups, we have 2 groups: neurocognitive disorder due to Alzheimer's disease. This is the most common cause of neurocognitive disorder, and the other groups of neurocognitive disorder, could be frontotemporal neurocognitive disorder, could be neurocognitive disorder with Lewy bodies, or it could be vascular neurocognitive disorder, or could be other causes like traumatic brain injury, could be medication-induced, could be HIV infection, Parkinson disease, Huntington disease. Look, very important here to mention Parkinson disease. It's one of the causes of neurocognitive disorder. This is very important to mention this. So again, in terms of major causes of neurocognitive disorder, the previous terminology, it was dementia. So we have primary degenerative etiology, and we have vascular etiology, and we have infectious etiology, we have traumatic etiology, we have rheumatological etiology, we have as well neoplastic etiology, and we have others. All of these are etiology or etiological classification of major neurocognitive disorder. So the two likely or two most common causes, it could be Alzheimer's disease. Alzheimer's disease here, one of the important differential could be, and the other differential, it could be dementia with Lewy bodies. Why this is very important here? Because this is one of the key clinical feature for dementia with Lewy body is Parkinsonism or Parkinson disease. So this patient, he has a history of Parkinson disease. But we have other differential, other causes could be frontotemporal dementia, or it's called Beck's disease, or Huntington disease. All of these are primary degenerative major neurocognitive disorder. We have vascular causes, vascular cognitive impairment, or previously it was called multi-infarct dementia. We have as well CNS vasculitis. It can cause neurocognitive disorder. Infectious causes like chronic meningitis, chronic encephalitis, chronic abscess, or HIV, or syphilis even. Traumatic brain injury, different type, could be diffuse axonal injury, could be epidural hematoma or subdural hematoma. Rheumatological, the most important is SLE. Neoplastic, different types of CNS neoplasia, it can cause this. And other types such as normal pressure hydrocephalus. Here we have this is the classification or etiological classification of neurocognitive disorder. So in terms of this two likely causes, I think the two likely causes, either it's acute onset of delirium due to sepsis, which the most likely cause of sepsis is a lower urinary tract infection, or it could be dementia. And the two likely causes of dementia, either Alzheimer's disease or dementia with Lewy body, which is common in patients with Parkinson's disease. This is the first part of this question. The second part of this question, he's asking about two likely causes for his physical decline. His physical decline, here we have the patient has suprapubic tenderness, and the patient is febrile and tachycardic, and he has new onset of nocturnal frequency. The cause here could be very important: UTI, urinary tract infection, contributing to this physical finding. And the other physical decline is the bruising of his knee. The most likely cause, the patient might have coagulopathy. This is very important. Coagulopathy, either because of warfarin-induced coagulopathy, or it could be sepsis-induced coagulopathy. So these are the most likely causes here in terms of cognitive decline and physical decline. Here, this table, it can differentiate between the 3Ds that causes of cognitive impairment. We have dementia, and we have delirium, and we have depression. And this table can differentiate in terms of the onset, each of them, duration, natural history, level of consciousness, attention, orientation, behavior, psychomotor features, sleep wake cycle, mood and affect, and cognition and memory loss. This patient, so most likely, according to the features and acute onset of this confusion agitation, most likely it is delirium related to his sepsis, which is caused by most likely by UTI. So this is the most likely. Here we have the causes of neurocognitive disorder. We have mild and major. Then the classification of causes of neurocognitive disorder. And here we have the causes of major neurocognitive disorder. And then after this, we have the intracranial causes of acute confusion. This patient has acute confusion, and differential could be vascular causes like subarachnoid hemorrhage, could be infectious causes, vascular either subarachnoid hemorrhage or could be stroke or TIA. Infectious could be meningitis or encephalitis or could be abscess, traumatic brain injury like diffuse axonal injury or epidural or subdural hematoma, autoimmune like vasculitis and different type of encephalitis, especially autoimmune encephalitis. Neoplastic could be seizure related, could be primary psychiatric psychosis, or could be other like drugs. Drugs is one of the differential. So the other things here to mention about the delirium could be the cause of delirium is the medication. The patient he is on Zabiclone and the patient he is on codeine. These medication, Zabiclone and codeine, and even these medication, carbidopa and levodopa, one of the side effects of this medication, it can cause acute delirium. So two likely causes here. Either it is delirium and it's related to sepsis, which is induced by UTI, or it could be medication related. It is Zabiclone and codeine and carbidopa and levodopa. All of these, it can contribute to acute delirium. In terms of dementia, it's most likely it's either Alzheimer's disease or either Alzheimer, or it's either neurocognitive disorder with Lewy bodies. So what's next here in terms of for his physical decline, this very important in the history. He's waking up 3 to 4 times at night, and this is most likely the patient has urinary tract infection. And the patient has bruising in his knee. This is the patient has element of a bleeding disorder, and this is indicates that the patient might have coagulopathy because of sepsis, and it could be because of warfarin induced coagulopathy. This is so clinical assessment tool. Then he is asking about clinical assessment tool would you use to screen for cause of his change in cognition. So the clinical assessment tool that can be used for screening of change in cognition. So we have different tools. There is no universal tool that can be used for assessment of cognition. The choice of appropriate mental state scale or cognitive state scale will depend on the clinical context, very important, and the setting. So we have 3 groups. We have short assessment, scales with shorter assessment, less than 5 minutes, and we can do this assessment. And these are example of these scales. And we have scales with moderate assessment. It is from 5 to 15 minutes it will take this assessment. And we have scales with longer assessment time, more than 15 minutes. If we are talking about short assessment scales, example of these, the informant questionnaire on cognitive decline in the elderly, IQ code, or could be MIS, memory impairment screen, could be 6-item screener, SIS, could be clock drawing test, CDT, or could be mini cog, one of the tests as well. And we have here short portable mental state questionnaire and abbreviated mental test score. All of these are short assessment tests. Usually they take less than 5 minutes. The other scaling system could be it's moderate, it will take 5 to 15 minutes, like mini mental state examination, MMSE. It could be MOCA or Montreal Cognitive Assessment, and it could be St. Louis University Mental State Examination. This is in terms of moderate assessment scale. In terms of longer assessment time scales, like we have, for example, computerized cognitive assessment. We have Addenbrock Cognitive Examination, ACE, and it could be this test, which is I think it is more specific for Alzheimer's disease. It can be used. So if you will choose any of these scales, either short one or moderate one or long one, it will be okay, because they didn't mention which type of scale. They ask about clinical assessment tool would you use to screen, without mentioning which one they are asking. So so here we have in terms if we are, these scales is used for cognitive assessment, and as well we have for delirium. And for delirium, if we are talking about delirium is a medical emergency carrying significant risk of morbidity and mortality. It's diagnosed when feature 1 and 2, as well as feature 3 or 4 are present. This classification is called CAM classification, confusion assessment method. So we have CAM classification. So I think this could be one. It could be as well, it's one of the answer or one of the classification it's used for cognitive assessment. It's called CAM classification, confusion assessment method. So the feature 1, it is acute onset and fluctuating course. The second feature is inattention, and these are essential. These two, it should be present. The feature 3, feature 4, one of them should be present, either feature 3 or feature 4. Feature 3, it is disorganized thinking. Feature 4, it's altered level of consciousness. So this classification or this scale is called confusion assessment method. This is for diagnosis of delirium mainly. So let's go to next question. A urine dipstick is performed, and he is asking about give 2 expected findings. So we already discussed previously that this patient highly likely has lower urinary tract infection and most likely cystitis. So one of the initial tests you have to think about, it's urinary dipstick. So dipstick here, indication and use: dipstick used to evaluate for urinary leukocyte esterase and nitrate. It can be used as a screening tool for diagnosis of UTI. Dipstick are generally performed whenever UTI is suspected. And here we have, what's the finding you might find? You might get leukocyte. You might get positive for leukocyte. Either it is either the amount could be it is mild or it's moderate, or it could be large amount. Nitrate as well, it might be tested positive for nitrate, could be tested positive for protein. This the finding. It could be tested positive for ketones if there is any element of ketones, but usually in the UTI you will find leukocyte and nitrate. This is the most likely finding in UTI, in patient with UTI. Name commonly frailty screening instrument, and it is correct cutoff score for frailty. So here we have clinical frailty scale. So here we have, as we can see, we have nine points or nine category. The first one is very fit. Second one is well. Third category, it is managing well. Fourth category, it is vulnerable. Here, the category 5, this is mildly frail. This is the cutoff for this scale, for clinically frailty scale. If we are talking about, so name commonly screening instrument. This is clinically, this is the name of the instrument or name of the scale, and the cutoff score. This is 5. If the patient scoring 6, it is moderately frail. If the patient scoring 7, it is severely frail, or very severely frail, it is 8, and terminally ill, it is 9. So this is according to clinical frailty scale. This is, so we have other scales. Yes, we have physical frailty. We have a tool that take only a minute to perform, and it can be incorporated into the history, taking about. It is called Frail Scale. So this scale is called the Frail Scale, and it is very easy to do this while you are taking history, which is presented in a slightly modified version here. The mnemonic, it's called the Frail. F, it is fatigue, and R, it is resistance. A, it is ambulation. I, it is illnesses, and L, it is loss of weight. And each of these, it has either 0 point or 1 point. So the maximum frail scale, it's going to be 5, and the minimum, it is 0. So it's from 0 to 5. So according to this frail scale score range from 0 to 5, and 0 is the best and 5 is the worst. And the frail patient, the patient considered to be frail if he's scoring more than or equal 3. So more than or equal 3, it's considered frail. Pre-frail, it is 1 to 2, and robust, it is 0. Robust health status. So this is other scoring system or other scale. It is called Frail Scale. So you can answer any of these, either clinical frailty scale, or you can answer as a Frail Scale, and the cutoff here, for example, 5, here the cutoff, it is 3. So the next question, name 2 medication listed that may be adversely contributing to the patient current condition. The patient has acute delirium. This acute delirium, it could be related to acute, in terms of acute delirium, could be related to zabiclone, and which is sedative, could be related to codeine, which is weak opioid. It has a central nervous system effect. It can cause this delirium. The Parkinson medication, carbidopa and levodopa, also it can cause this confusion state and delirium. In terms of bruises in the knees, bruises in the knees, it could be related to warfarin. It could be related to warfarin. So it is here very important to mention the drug and mention what's the link with the patient presentation. For example, warfarin related to bruises in the knees, and codeine and zabiclone and Sanimet related to acute confusion and delirious state. So the next question, how would you manage the patient current clinical problem? So here, confusion and agitation. The patient has confusion and agitation. This is one problem. And the patient has acute onset of loss of memory, short-term memory. We have to answer this part of the question in terms of management. And the other thing, the patient has new onset of most likely UTI, urinary tract infection, and the patient has as well bruises in his knees. All of these, it has to be discussed in the management. In terms of management of this patient, he's old age. So we have what is called CGA. It is comprehensive geriatric assessment approach. Comprehensive geriatric assessment approach include, we have to take past medical history and it's already given in the question, medication and it's already given in the question, allergic history, it's already given in the question, social history and function, and geriatric review system in terms of cognition, mood, sleep, pain, nutrition, falls, continence, vision and hearing, skin and safety. Physical examination is already given in the question. So here investigation is very important to screen for anemia. So you have to screen for infection and for inflammation. So you have to order a complete blood count or FBC full blood count, urine analysis and urine culture. Here we have patient is suspected to have lower urinary tract infection. Coagulation profile here very important because we are suspecting the patient has coagulopathy. So we have to check the bleeding time, prothrombin time, partial thromboplastin time, and international normalizer ratio (INR). Electrolyte here as well as a part of a comprehensive geriatric assessment. Metabolic, we have to check thyroid function test, TSH, serum TSH. We have to check vitamin B12, vitamin D level, liver function test, and extended electrolyte like serum sodium, potassium, calcium, phosphate, and magnesium. Because these electrolyte changes, it can explain, or it can be one of the differential, especially the sodium changes. It can explain the confusion state that the patient is having at the presentation. Drugs, very important to drugs and toxin and withdrawal. Medication review, very important, because here we have few medications that can explain the patient confusion state. Structural tests, we can order, we have to do full and neurological examination, and we might order CT scan of the head. So interdisciplinary primary care and referral to acute care for elders unit if required, and interdisciplinary and multidisciplinary team here. We can ask for geriatric specialist or consultant to review the patient. And in terms of pharmaceutical care and medication optimization is very important here in the management. We have to stop few medication that might contribute to further deterioration in the cognitive state. For example, the codeine and zabiclone has to be stopped. Warfarin also. We have to check the coagulation profile of the patient. If the INR is high, above the therapeutic range, the warfarin has to be stopped. So these changes in the medication is very important. Management of geriatric syndromes. If the patient has falls, the patient have cognitive impairment here, it has to be managed here. And incontinence, if the patient has incontinence, and caregiver support. All of these are included in the comprehensive geriatric assessment. So in terms of neurocognitive disorder or dementia workup, we have to rule out reversible causes of neurocognitive disorder or dementia, CBC. We are looking for MCV as evidence for alcohol use or as evidence of B12 deficiency. Usually in the B12 deficiency, MCV will be high. In the alcoholic as well, it will be high, usually microcytic anemia. Glucose, we have to check for hypoglycemia. TSH, we have to check for hypothyroidism. B12, vitamin B12, and folate to check for B12 deficiency or folate deficiency. Electrolyte, liver function test to check for hepatic encephalopathy as a cause of cognitive impairment. Renal function to check for uremia and uremic encephalopathy. Lipid profile and serum calcium. CT scan of the brain CT scan and MRI as indicated. As clinically indicated, we in terms of infection and other screening tests, for example, VDRL, this is for syphilis. If we are suspecting the patient has syphilis, HIV, ANA test for suspected or query SLE encephalitis, anti-double-strand DNA, this is as well for SLE, ANCA for different type of vasculitis, ceruloplasmin if we are suspecting Wilson disease, serum copper level or cortisol level, toxicology screen, and heavy metals test. Issues to consider here in the workup or in the patient with neurocrine disorder, failure to cope and fitness to drive. Caregiver is very important to consider. Capacity and well-being, legal well and advanced medical advanced medical patient and caregiver safety. All of these it has to be considered in the management patient with suspected to have neurocognitive disorder. EEG usually it's normal in mild to moderate stage of dementia. We might find slow wave in moderate to advanced stage. MRI, we might order an MRI or CT scan, special type of CT scan. It's called SPE CT scan. I think it is it's a photon electronic CT scan, and beta imaging. It can be done as a workup, and lumbar puncture in the patient with Alzheimer's disease as a cause for neurocognitive disorder. You might find amyloid beta protein can be measured in the CSF, and this is indicate the patient might have Alzheimer's disease. So here we have assessment and management for patient with delirium. If we are talking as in the differential, the delirium is the cause. So here we have what we have to do in terms of management of patient with delirium. We have to review the medication. We have to do focused history and physical examination and obtain basic laboratory tests like CBC, glucose, electrolyte, creatinine, PU, calcium, urine analysis, and pulse oximeter and ECG. And if then after this, after all of this, we have to rule out other causes by doing, for example, brain CT scan, or if we suspect if the patient has, for example, infection, we have to treat the infection by giving antibiotic here. Very important to give the patient. So in the management here, patient has most likely UTI, so you have to start antibiotic. And this starting antibiotic could improve and resolve the acute delirious state. If the patient has element or suspected to have meningitis, we have to do lumbar puncture. If the etiology is still unclear, we have to check vitamin B12 level, thyroid test, thyroid function test. We have to consider EEG, brain MRI, and drug levels, and toxin screen. These the usual management. So in terms of delirium state and agitation state, in terms of management or therapeutic measures, most of these are diagnostic measures in the management, and we have therapeutic measure in the management. Therapeutic measures in the management, usually in the delirium, we are starting with supportive measurement. Supportive measures like maintain hydration, avoid restrain, mobilize the patient, reduce noises, orientation, stimuli, reassurance, bedside sisters, managing the pain, and treat underlying medical condition. This is the usually we are starting in any patient with acute delirium. Next step, if the patient still in delirious state and the patient still poorly managed delirium, so next step we have to think about so we have to ask ourselves, does the patient behavior interface with the care and safety? If the answer is yes, so we can, the first line medication or pharmacotherapy, it is low dose neuroleptic agent. Haloperidol is the first line. And this is the usual algorithm or how to manage the assessment and management of patients with delirium. So again, this is here the major neurocognitive disorder consideration for management of management of major neurocognitive disorder. It is affective disorder and activity of daily living. We have to consider these, how the patient will manage activity of daily living. B, it is A, and B, it is behavioral problem. We have to consider these things. C, caretaker and cognitive medication and stimulation. D, we have to consider directives and driving. And S, it is sensory enhancement like glasses and hearing aids. All of these should be considered in the management of major neurocognitive disorder if we are considering this patient has dementia or early onset of dementia. So the other things in the management, when you are the answer for this question, it is the management for UTI. So in terms of management of UTI, very important. This patient might have sepsis, so you have to start sepsis 6. What is the sepsis 6? You have to take 3 things, and you have to give three things within first hour of suspected sepsis. So 3 things you have to take. You have to take full blood count and routine blood tests, routine laboratory tests, and you have to check serum lactate, and you have to send culture here. Very important to send urinary sample for microbiology and for culture, and blood culture as well for suspected sepsis. And the 3 things to give the patient oxygen if the patient is hypoxemic, and to give IV fluid here, and to give IV antibiotic. Usually we are giving antibiotic according to local guideline, according to the hospital guideline that cover the most likely cause of the infection. Here UTI, most likely etiology is E. coli, Escherichia coli. So this is the management in terms of the other type of management around bruising in his knees. The patient has element of bleeding, so we have to check coagulation profile, and if the INR is above the therapeutic range, we have to stop warfarin and consider vitamin K, and if the patient has any element of unstable bleeding, we might consider prothrombin complex concentrate. It's called PCC. This is the antidote of warfarin. So this is the other thing in the management. In the management, very important to mention, you have to review the medication and stop the medication that might contribute to the patient current presentation. For example, the codeine has to be stopped. Zabiclone has to be stopped as well. So this is the management. So his condition deteriorated. He became more agitated and aggressive. So here we have progression of the patient cognitive state. The patient become more agitated and aggressive and tried to leave the ward. At 3 a.m., he fell out of the bed and landed on his right side. You are a medical intern on call, and we were asked to review the patient. You are unable to take history because of his confusion. Provide for finding on the examination horn. Here, very important to mention, they are asking about finding in examination. So you have to mention signs or physical examination finding, which you would look for. And what step would you take to manage this patient agitation? So physical, very important here, physical exam finding for geriatric patient who has fall. So you have to check the vitals. You have to check vitals. First of all, you have to check vitals. Vitals, we all know vitals include the airway-related vitals and breathing-related vitals, which is the autosaturation. You have to check the autosaturation. You have to check the respiratory rate and check if the patient has any signs of tachypnea or respiratory distress auto saturation. You have to check if the patient has any element of desaturation, and you have to give the patient oxygen. And you have to check if the patient has any element of desaturation. You have to start oxygen either with a nasal cannula or simple face mask or Venturi mask or non-rebreather mask. So vital sign related to airway and breathing, vital sign related to circulation, which is the heart rate. You have to check the heart rate. You might find the patient might be tachycardic, the patient might be bradycardic, and you have to check the blood pressure. Blood pressure here, very important. The patient might have hypotension, hypotensive episodes that lead to this fall. Or the patient might have hypotension that developed after falling. So you have to check heart rate and blood pressure, and the finding that you might find hypotension in the finding. And we have vital related to disability, which is the very important here, level of consciousness, and AVPU score. You have to check level of consciousness. If the patient is alert and awake, if the patient is responsive to voice, if the patient is responsive to pain, if the patient is unresponsive. And according to these, you have to do the intervention. If the patient is unresponsive, you have to check the glass coma scale of the patient. And according to glass coma scale, you might do intervention like securing the airway if the glass coma scale less than or equal to 8. So A, B, C, D, and E exposure, you have to check the temperature of the patient, and you have to check the environment. Here, the environment, if the patient he is in the regular ward, because he mentioned that the patient he was in the regular ward. I think this environment is unsafe for such patient. The patient must be escalated. His care must be escalated into one-to-one level of care, which is like a high dependence care unit. The other things in the finding, very important to do. This is orthostatic blood pressure, cardiac. You have to do cardiac examination for the patient, full cardiac examination. You have to check visual acuity, could be related to vision problem in this age group. Musculoskeletal examination to check for any trauma, upper limb or lower limbs trauma, or trunk trauma, or very important traumatic head trauma. Check for any signs of head trauma. And neurological examination here, very important. Any neurological deficit, any signs of central nervous system impairment, or signs of traumatic brain injury in general. These are findings you have to check. What steps would you take to manage the patient agitation? In terms of management of patient agitation, already discussed before, and this algorithm show how we are doing assessment and management. The management, usually we are starting with supportive measures, as I mentioned before. If the supportive measure failed, we have to go and we have to start pharmacotherapy. The first one pharmacotherapy is low-dose neuroleptic agent like haloperidol. Or we have other medication. It can be used for delirium, like antipsychotic medication like quetiapine or olanzapine. All of these can be used as a part of management of acute confusion state. The other things, you have to consider reversible causes. You have to treat reversible causes of delirium. Reversible causes of delirium here, most likely it could be the drugs. You have to stop all of the medication that contributing to this, and the other things, the UTI, the infection, you have to treat the infection. So the patient recovered well, and the patient son had helped him with cooking and cleaning at home, but due to personal circumstances is now less available to help his father. The son noticed that his father had slowed up and become less mobile before he is due to take his afternoon and evening dose of cinnamon. So this is what is called we have here deterioration in the patient condition in terms of Parkinson's disease. The patient, the son has noticed that the father is slowing up and taking of his medication in the afternoon and evening become not in the appropriate time. It is a little bit later. So, and he is getting worse with symptoms beginning earlier. So this question: what is the name of this phenomenon? The name of this phenomenon, in terms, so you have to review the Parkinson's disease, and here the name of this phenomenon is called wearing off effect or wearing off phenomenon. This wearing off phenomenon, it's characterized by re-emergence of Parkinson's symptoms as the effect of levodopa diminishes near the end of the dose interval, usually 3 to 4 hours after the dose. Wearing off is often the first and most common encountered fluctuation in the patient with Parkinson's disease. The deterioration in the patient with Parkinson's disease, the first and the most common type of deterioration, it's usually it comes in the form of wearing off phenomenon. Approach to wearing off, he is asking, suggest 2 approaches in managing this. Approaches for wearing off, there is a variety of strategies that can be helped to treat or to manage wearing off phenomenon. For example, dietary adjustment. This is one of things, because absorption of levodopa in the duodenum and its transport across the blood-brain barrier facilitated by large neutral amino acid transporter protein. So ingested protein has the potential to compete with levodopa transport in the gut and brain. And thereby this reducing the levodopa clinical benefit. So I think the ideal here to try to take the medication on the empty stomach, which is 30 to 60 minutes before or 60 to 90 minutes after the meal, and avoid the protein at the time of the drug administration. This is the other option, dietary adjustment. In terms of other strategy, levodopa dose and interval adjustment, we can increase the dose, and we can increase the frequency. So for patients who are in low dose levodopa, we can increase the dose, and the patient in low frequency, we can increase the frequency. The other strategy, a role of longer acting oral levodopa formulation like CR, controlled release tablet, or newer, which is ER, extended release capsule. The other strategy is adjunct therapy. If levodopa adjustment for wearing off effect are not adequate or tolerated, the addition of adjunctive therapy like dopamine agonist or methyltransferase inhibitor or monoamine oxidase B inhibitor is the other option how to treat this phenomenon. What members of the multidisciplinary team would be helpful to introduce at this stage? I think it's helpful to introduce at this stage neurologist. The neurologist to discuss the Parkinson's disease and deterioration in the Parkinson's disease. So neurologist is one of the multidisciplinary team. And the other specialist, I think geriatric specialist or geriatric medicine specialist, it can be consulted here to discuss the overall geriatric assessment for the patient. Explain how would this member contribute to the patient care. Neurologist in terms of deterioration of Parkinson's disease and for optimization of the wearing effect phenomenon, and geriatric. And geriatric, it is to do what is called comprehensive geriatric assessment. What is the process of interdisciplinary evaluation? This is called comprehensive geriatric assessment. It is CGA. What's the risk factor are present to suggest that this patient might have delayed discharge? The risk factor here, the patient has confusion and agitation state. This is confusion and agitation is a risk factor. The other things, the patient has deterioration in Parkinson's disease. So this deterioration in Parkinson's disease can indicate the patient might have delayed discharge. The other things is the fall, the history of fall. The history of fall in hospital, this is the other, also indicate that the patient might have delayed discharge. The history of fall and confusion and delirium and deterioration of confusion and delirious state. And the other things, it's the deterioration of the Parkinson disease. And this is the question number 1. I will finish here and I will do the question number 2 in separate video. I would like to hear from you if this type of explanation is helpful to you for your preparation for your short answer question. You can just email me or text me, and I am happy to get the feedback from you. Thank you very much.